the presentation. Well, I will start by telling you that there are a lot of first trimester markers of abnormal development, and as you all are aware, the most important one is the nuchal translucency. So I will first talk very, very shortly about that, and then about all the other first trimester markers that we know, and there are more and more appearing. So as I said, secant nuchal translucency is the most important one, and it is obvious that sometimes in combination with the enlarged nuchal translucency we will see also other markers, like for instance absence of the nasal bone. And if we look at the heart, it may be very obvious that this fetus has got also a heart anomaly, and then it may even be superfluous to do a chromosomal anomaly. Well, obviously it's a joke, but the chance that this fetus will have a trisomy is very high, especially if the anomaly that we see, as in this case, is a AVSD. It's a different story when, after having performed karyotyping and after having excluded that there are other obvious anomalies at the time of the first trimester scan, we have a normal karyotype. Because we know out from our experience of many other groups, that in case of an increased nuchal translucency and normal karyotype, in about 20% of the cases, the outcome will be unfavorable. And we also know that there is a linear relationship between the initial enlargement of the nuchal translucency and the chance of this abnormal outcome. What do we intend for abnormal outcome? Well, the abnormal outcome could be a pregnancy loss, miscarriage, intrauterine death. It may be the fact that the patient has decided to terminate the pregnancy, even in spite of the normal karyotype, usually because there is a severe hydrops. Or it may be the fact that later in pregnancy, and I would say that now this later in pregnancy is becoming less and less relevant with the enormous advances of the first trimester scan, but it may still be possible that a structural and especially a genetic syndrome will be diagnosed later in pregnancy. And as you can see here in this table, we can look per degree of nuchal enlargement, which is the chance that one of these events will happen. And altogether, we know that in about 12% of fetuses with a normal karyotype, it is possible that a structural anomaly or a genetic syndrome plays a role. Well, fortunately, and this was a question that was asked earlier on, if no anomalies are seen at follow-up scans, and this study was based on the 20-week scan, but I think that more and more we can anticipate this time of reassurance to earlier moments in the pregnancy. The chance that the outcome of pregnancy will be uneventful is extremely high, and this is almost irrespective of the initial degree of enlargement. It is obvious that there will be very few fetuses with a very large nuchal that will have an uneventful outcome, because we are very likely to find something. But even in these cases, if the nuchal normalizes and if we don't find anything else at follow-up scans, we may confidently reassure the parents. It's more tricky as far as the genetic syndrome is concerned, because some of those are associated with clear structural abnormalities. But in some cases, the abnormalities may be subtle, and in some cases, the diagnosis may only take place after birth, and sometimes even quite a long time after birth. Well, if we look at this very long list where all kinds of possible abnormalities are summarized, and although the list is becoming longer and longer, there are especially two abnormalities, one in the structural side and one in the genetic syndrome side, that are very strongly associated with an enlarged nuclear translucency. And of the structural anomaly, the one, and you have also heard it many times in the today, the anomaly which is more frequently associated with the abnormal nuchal is the cardiac anomalies, and of all the genetic syndrome, the one which is more commonly found in association with an enlarged nuchal is Noonan syndrome. John Hyatt was the first one to point out this association between enlarged nuchal translucency and cardiac defect, and after his publication in 1999, there have been a lot of other publications that, because we're dealing with less high-risk population, found a less strong association, not 56% as in his study, but a lower degree of association, about less than 15%. But if we look at the most up-to-date meta-analysis on the subject, we may conclude that an enlarged nuchal translucency is associated with about 40% of cardiac defects. And what the study of 2008 pointed out was that are especially the cardiac defects which are likely to benefit of prenatal diagnosis, and by that we refer especially to those cardiac defects where the child may highly benefit from being born in a highly specialized center, are those which are more frequently associated with the increased nuchal translucency. So there is no doubt that an enlarged nuchal translucency is a reason for referral for specialized echocardiography. A number of groups have reproduced more or less the same figures, and the association is exponential according to the initial degree of enlargement, and it varies from 2% there where the degree of enlargement is minimal to about 10% there where the degree of enlargement was more than 5.5 millimeters. It's a very intriguing subject which has not been completely sorted out yet. What is that makes this association? Which is the pathophysiological background? Is it a cardiac dysfunction, as we may infer by the fact that the ductus venosus and the tricuspid regurgitation are abnormal? May it be a disorder of vascular and neurogenesis, as it has been suggested by certain groups, or may it be a kind of early fetal flow disturbance due to some external factors that may produce this association? Well, what we know for sure is that next to the nuchal translucency, also other fetal markers are present, and well, the tricuspid regurgitation has been already addressed, and the abnormal ductus venosus, and the combination of the increased nuchal translucency and the other markers may indeed, if the chromosomes are normal, suggest that the likelihood that there may be a problem with the heart is very high. In this case, for instance, what we could see already very early on was the fact that there was a retrograde flow in the aortic arch, and at a later stage in pregnancy, we could very clearly see that there was a disproportion and a coarctation. This was another case where next to an increased nuchal translucency, we could see a very abnormal ductus venosus flow. And as you can see here, I have some video clips which are a little bit difficult. Well, let's hope that. As you can see here, this was in the first trimester. Well, this is a case of tricuspid atresia. You can see already here in the 4-chamber view that there where you would expect the tricuspid valve to open, there is a white line, and with no excursion of the tricuspid valve. And if you look with color, you see that there is only the filling of one of the 2 chambers. I hope to be able to show it to you. I will ask later to Rabi a crash course in how to be more efficient with my video clips. Well, anyway, it's a shame that I cannot show it to you, but well, this is another case. This was again a fetus with an enlarged nuchal translucency, and I was quite lucky to see very clearly that there was a VSD and a overriding aorta in this case. And as we can see here in this other clip, if we will be lucky, is that there is a discrepancy between the 2 outflow tracts, with the aorta which is definitely much larger than the pulmonary artery. So we can see there the discrepancy between the overriding vessel and the smaller pulmonary artery. I'm sorry, but this is not going to work. Well, we will carry on.
Do you have power?
Yes, I have power. Yeah. At least I hope that it's, yes, I have power. Well, if I manage to go ahead and to go to the next slide, I will show you a case of Noonan syndrome. And Noonan syndrome is classically associated with very enlarged nuchal translucency, and sometimes also with venous anomalies. Well, I don't know what I have to do here. Well, I'm really sorry about this. Okay, so this is the case of Noonan syndrome. As I told you already, usually in Noonan syndrome we see very, very large nuchal translucency. What we may also see sometimes are venous return anomalies, like in this case where we were unable to see ductus venosus, because sometimes in Noonan syndrome the ductus venosus is absent. And what is also typical of Noonan syndrome is the fact that the nuchal edema persists also in the 2nd trimester. Sometimes even at 20 weeks you may still see the persistence of the enlarged jugular lymphatic sacs or some kind of cystic hygroma-like edema in the neck. Well, in actual fact, what are the signs that should make us suspect a Noonan syndrome in the 3 trimester? So in the 1st trimester, as I said already, a very large nuchal translucency, and then from the 1st trimester onwards, the persistence of this nuchal edema with cystic hygroma, of the presence of some fluid somewhere in the body, brachycephaly, the presence of renal anomalies of hepatomegaly, and in the 3rd trimester, polyhydramnios, cardiac defect, and especially pulmonary stenosis of some kind of cardiomyopathy, may really make us suspect this diagnosis, which sometimes will be a late diagnosis, unless in your institution you always test for Noonan syndrome every time the nuchal translucency is, for instance, more than 4 millimeters, what we are presently going to do. Also because the diagnosis recently has can be performed in a shorter time with respect to in the past. Other typical features of Noonan syndrome later in pregnancy are hypertelorism, high forehead, a depressed nasal bridge, a broad nose, and a prominent lip and a small mouth, and abnormally rotated ears. All the features that you may be able to suspect by 2D and that may be confirmed by 3D. Another anomaly which is very commonly associated with enlarged nuchal translucency is the cleft, facial cleft, cleft lip and palate. And in this study, what we observed was that a nuchal translucency carries a 19 relative risk for any kind of cleft, much higher, 53, if the clefting is associated. And now let's talk about Doppler in the first trimester, because next to the nuchal translucency, Doppler has become extremely important. Well, we mentioned already the ductus venosus and the tricuspid regurgitation, and these are a number of papers already quite old that have looked at the capability of ductus venosus flow in let's say, predicting chromosomal abnormalities. As you can see, the detection rate is quite variable according to the different study, and altogether we may say that ductus venosus may be abnormal in about 70% of the chromosomal abnormalities. So what is very intriguing is also to try to find a link between the abnormality of the ductus venosus and the fact that in these cases of increased nuchal translucency and abnormal duct, the likelihood of finding a cardiac defect is much higher. What does produce the abnormal ductus venosus? Is the cardiac defect? Are the two things associated? Is the ductus venosus a consequence of the cardiac defect in the sense that is indicative of cardiac failure, or may the abnormal ductus venosus be purely a reflection of abnormal pressures in the right ventricle? Well, one thing is clear, that the abnormality in the ductus venosus and the enlarged nuchal translucency are very closely associated. That probably we are looking at the same kind of pathophysiologic background, even if it's not 100% clear what we are looking at. Well, we may remember the fact that both the heart, of at least very important parts of the heart, and the ductus venosus are originating from the neural crest cells, and therefore this association may not be fortuitous. I just want to remember you that the interpretation of the ductus venosus flow can be quite challenging because we must be aware of some technical pitfalls. For instance, that if we are also interrogating a little bit the umbilical vein, and our sample gate is not exclusively placed on the ductus venosus, we may have, let's say, an obliteration of the lower part of the frequency, so we may erroneously conclude that there was a positive flow, whereas this is the superimposition of the umbilical vein, and we may not be able to recognize an abnormal flow. On the other hand, another possible pitfall is the fact that because the ductus venosus is also very, very close to the hepatic veins, we may falsely interpret some kind of retrograde flow in coincidence of the A wave that in actual fact is not of the ductus venosus itself, but is a superimposition with the hepatic vein. So there are all possible sources of misinterpretation, and next to that there is also the fact that it's quite common to see in a fetus that a reverse or absent flow during the A wave may coexist with a normal waveform. So, which means that the interpretation of the ductus venosus may not always be very simple. What is clear from the literature is that the finding of an association between enlarged nuchal translucency and abnormal ductus venosus flow increases the chances of finding a cardiac defect. This is demonstrated already by many groups. This was also showed earlier on today. This is, for instance, the study of Mainz from the group of Kypros Nikolaidis. And they did also an overview of the literature, and as you can see, it's very common in a cardiac defect to find the abnormal ductus venosus flow. And we can use, therefore, the ductus venosus next to the nuchal translucency as a way of increasing, of reducing the likelihood that we will find a cardiac defect in association with the nuchal translucency. This group from Spain concludes that the finding of abnormal ductus venosus flow is for sure an indication for early echocardiography, and that it increased the detection of cardiac defect by about 11% with respect to the detection rate purely based on the nuchal translucency alone. This is another interesting case that we saw. It was a monochorionic twin pregnancy. Both fetuses had enormously enlarged nuchal translucency. Well, you see here in a cross-sectional view, it's almost a kind of a cystic hygroma view. And what we saw later in pregnancy, well, also in the first trimester, we saw very clearly that there was an abnormal, the ductus venosus was the umbilical vein was going directly into the vena cava inferior. There was no ductus venosus. And what we saw later in pregnancy was the fact that also here there was a retrograde filling of the aortic arch. And as you can see here, later on in pregnancy, the nuchal had completely disappeared. The two fetuses, it was almost amazing to see how these had normalized. But as you may appreciate in the heart, there was a clear disproportion with a smaller left ventricle and a smaller aorta. And in actual fact, both fetuses had a very severe coarctation, and they both died after birth, and probably it was a syndrome which has thus far not yet been clarified and diagnosed. Absence of the ductus venosus, I said that we can see it in combination with Noonan syndrome, we can see it in combination with other genetic syndrome, but it seems that the condition where the ductus venosus is mostly absent is Turner syndrome. So if we see a very large nuchal translucency of a hygroma and we see no ductus venosus, we may be quite sure that we are dealing with Turner syndrome. In this study, they looked at the different percentages of ductus venosus abnormality in relation to trisomy, other all aneuploidy of congenital heart defect, and as you can see, they say that in 37% of the cases of no ductus venosus and a very large nuchal translucency, the diagnosis of Turner syndrome was made. So the take-home message regarding this part of my talk is that ductus venosus flow is sometimes challenging to interpret. An abnormal ductus venosus flow is associated with chromosomal anomaly, cardiac defect, and genetic syndrome. The association with abnormal outcome is stronger when the NT is also increased, and an absent ductus venosus can be a normal variant, can be associated with abnormal cases, and is especially associated with Turner syndrome. Well, tricuspid valve regurgitation, there are various degrees of regurgitation, of abnormality. Also, this one is seen very often in combination with increased nuchal translucency, and we know that there are certain criteria to define regurgitation. It should occupy more than 50% of the systole and have a velocity which is more than 60 centimeter per second. In some cases, the regurgitation is so severe that you can even see it. You don't even need to use the colors, like in this case. I hope that you will be able to see it. And it's also important to be aware that if the criteria that I have named are not met, we may looking at something else which is not a regurgitation. For instance, in this case, what we are looking at is not the regurgitation, but is purely an outflow tract. And a way of knowing that is that usually you see that this flow during the systole doesn't start immediately after the A wave, but at a certain distance, and usually is encompassed between the clicks of the aorta of the pulmonary artery. Tricuspid regurgitation has got an association with chromosomal anomalies and also an association with cardiac defects, as we can see here. And this group has concluded that if tricuspid regurgitation is isolated and usually is not very severe, then the predictive ability of the tricuspid regurgitation alone for associated anomaly will be very low, and therefore it shouldn't be really a reason of concern. So the conclusion in this case is that in aneuploidies, tricuspid regurgitation is frequently found in association with other markers, whereas if it is alone, the performance as a screening for cardiac defect will be extremely low. And then I want to talk to you briefly about the hepatic artery. It's a marker that my group has described already some years ago. You see it on the opposite channel of the ductus venosus. You see usually an abnormal ductus venosus, and on the other channel you see this quite distinct positive and continuous flow. The first situation in which the hepatic artery flow has been described is especially in the second trimester in fetuses suffering of growth restriction. And here in the audience there is also Catherine Ebbing, who has done some study on this. And it seems as if the pathophysiological mechanism of a abnormal hepatic artery flow, which means a very increased flow in pregnancy, is to be ascribed to the fact that there is a reduction in the portal circulation, which is the main source of blood supply to the liver, and therefore the hepatic artery, which is usually not very active in supplying the liver, has got to take over and to send more blood supply to the liver in these cases. These cases may be due to anemia, may be due to hypoxia. And what we noticed was that in the first trimester of pregnancy, sometimes you also see an enormous increase in the blood supply in the hepatic artery, as opposed to the normal situation where you hardly see the vessel. And you also see a clearly continuous forward flow in this vessel, as opposed to this situation in the normal case where you see only a peak, a systolic peak, and no diastolic flow. Well, also to investigate this vessel, you have to use a small sample gate, and probably what happens is that when more blood is diverted to the ductus venosus, and therefore at the expenses of the portal circulation, the hepatic artery has got to intervene to supply the liver, and therefore we will see an increased flow in this vessel. Why this happens in the first trimester of pregnancy is really unknown. What we could see in our experience is that an abnormal hepatic artery flow is associated with trisomy 21, and even if when we corrected for ductus venosus and tricuspid regurgitation, this association was still present. And we also saw that it can be associated to genetic syndrome and to, let's say, generic condition that will result in a poor fetal outcome. I show you, for instance, this case. This was a case of a pregnancy with a fetus with a large nuchal translucency, abnormal, umbilical vein which was persistent was the left umbilical vein, which is usually the one that should disappear. The umbilical vein was also draining directly into the inferior vena cava. And also what we saw very interestingly was the fact that there was a extremely evident hepatic artery flow, as you can see here, and together with the abnormal ductus venosus flow. Well, this pregnancy hasn't been delivered yet, the baby hasn't been born yet, but at present there is a polyhydramnion and all kind of abnormal facial features, so we really think that also here there may be some strange genetic syndrome that we were thus far unable to diagnose. This is another pregnancy. Also here, as you can see, abnormal hepatic artery flow, clearly micrognathia and also micrognathia, and also a defect of the palate. Well, when we see a severe micrognathia because of the Pierre-Robin syndrome, we saw very nice pictures this morning from Gustavo. We know that there must be also a palatal defect. So the take-home message regarding the hepatic artery is that whereas later in pregnancy hepatic artery flow is increased in growth retardation and in growth restriction in anemia, the exact pathophysiology in the first trimester is still unknown, but we know that it can be associated with chromosomal anomaly, heart anomalies, genetic syndrome, and therefore it can be considered an ominous sign. Abnormal absent nasal bone, well, we know that absent nasal bone is associated with chromosomal anomalies, and in this quite a recent study, what they concluded was that beside the trisomies, in 5% of the cases, they also had microdeletion and genetic syndrome associated with the absence of end-diastolic flow. Therefore, RSCGH may be indicated in all these cases, and then ultrasound follow-up is also indicated to exclude other anomalies. Single umbilical artery. it's quite common to find a single umbilical artery in the first trimester, whereas we know that the prevalence of the single umbilical artery later on in pregnancy may be about 0.5%. In the first trimester may be as high as 6%. But mind you, it may be a false positive diagnosis, because for instance, in this case, I thought in the first place that there was a single umbilical artery, and then by looking more carefully, I saw that in actual fact both arteries were present. So it really depends very much on how you are using your, angulating your probe, and therefore you must be very careful before you make the patient worried by telling her that there was a single umbilical artery. Prenasal thickness and nasal bone have been used in the second trimester as a very strong marker for chromosomal anomaly, especially in combination, the ratio between the two of them. And our group and also the group of Anna-Grete Gapel in Bonn have shown that these markers can already be measured in the first trimester of pregnancy with a very high sensitivity for chromosomal anomaly, a sensitivity which in actual fact is similar to the one of the combined test, but obviously to measure, to perform the combined test may be easier than to measure these subtle markers in the first trimester. I've almost finished. There are other facial markers, and maybe I will be short on this because I'm sure that tomorrow Rabbi will talk on other facial markers in the first trimester. The M&M angle, which has been measured in the second trimester, the mandibula, nasion, maxilla, is a very good marker in the second trimester, but also in the first trimester, if it is reduced or increased, can be associated with micrognathia or with bilateral cleft. And the same applies to this PFSR ratio, which, as shown by this recent paper by Hoffman, may be an indication of schisis or of retrognathia, according whether it is increased or decreased. And here there are some cases. Well, you may argue you don't need to measure it in this case, and I fully agree with you. So it can be more speculative than. And we also heard today that we have always to measure everything, but in some cases it may not be really necessary because it's obvious that these fetuses have anomalies. ARSA has been already mentioned today, and we know that ARSA can be an indication for chromosomal anomalies. It can also be found in the setting of cardiac anomalies, as we have already heard. And I think that it's very important because this is a very simple marker to look at the heart axis. Because we know that the heart axis should be about 44 degrees in pregnancy and also in the first trimester. And we know also from this study from Elena Sinkovskaya that in 74% of the cases of cardiac defect, this cardiac axis was already abnormal in the first trimester of pregnancy. And in 56% of the cases there was a left deviation, and in 10% there was a right deviation. So I would advise you to learn to look and to measure this marker because it may be very, very useful as an indirect indication of cardiac defect. And I come to the conclusion of my talk, which maybe was a little bit too long, sorry about that. And the conclusions are that there are multiple first trimester markers of abnormal development. Nuclear translucency is the strongest, and in actual fact overrules all the others. All the other markers, when isolated, are poor predictors of aneuploidies and of a cardiac defect. Ductus venosus and hepatic artery abnormalities are associated with an unfavorable outcome, but are rarely isolated. And profile abnormalities can already be diagnosed in the first trimester, and angles or lines can be objective tools to assess the severity of the facial abnormalities. And I thank you very much for your attention.
So again, we are opening for questions. We have from the audience some questions. There is a question for Asma from the internet. Asma, are you here?
Yeah.
Yes. The question is, what will you do when there is early CRL discordance in twins? Come here, because if not, they will not hear.
Can you hear me now?
In
Or
twins,
shall I go
there
on?
is early discordance. From this one.
Okay, so if there is a discordance of 10% or more, you do a detailed anomaly scan. If you find abnormalities, of course, you'll offer prenatal diagnosis or CVS. If there is none, I still do offer prenatal diagnosis. I still offer CVS if there is a significant discordance in the size, even if you don't see any abnormalities. And then if this is normal, I would just follow up the pregnancy as usual. So if it is a monochorionic, it will be every 2 weeks. If it's a dichorionic, every 4 weeks, unless there is a discordance in the size later.
And what about the follow-up for malformation that may be not apparent this time?
So first trimester, detailed scan. If there's abnormality, fine. If there's no abnormality, I still offer CVS.
Okay.
And if there is...
The CVS is normal? Do you continue to follow the patient?
Yes. Yeah, so you still will be looking for abnormalities later because you might miss cardiac abnormality, for example, in the first trimester that might become apparent at 20 weeks.
Okay. I have a comment from your lecture. When you look for Noonan, it's very, very important to look at the parents. Because it's an autosomal dominant condition, and and the father maybe 1.6 m and have Noonan, and no one will recognize that.
I also had cases where, in actual fact, I made the diagnosis in the mother and in the fetus at the same time. But we know also that a lot of Noonan are new mutations.
Yes,
so.
yes, but
Always when you find an abnormality, look at the parents.